Yes. Dr. Carlos, are you with us?
Yes, I am. Thank you.
Yes. Hi. Okay, we'll start our next session. Dr. Carlos Aguiar, he's a consultant cardiologist in Santa Cruz Hospital in Lisbon, Portugal, and he's a staff physician at the intensive care unit in the hospital. He will give us a lecture about modern approach for hypertension management. So join me in welcoming Dr. Carlos, and yeah, we're very interested in listening to your exciting lecture, Doctor.
Thank you very much, Youssef. Thank you to Jalfer for inviting me over to the Cardiometabolic Summit, and thank you to all of you for staying and listening into this lecture, which is on an important subject. We tend to perceive that hypertension is an easy thing to control. We've done all we need to do. There's really nothing more to be done. But the face of hypertension has also been changing. The risks associated with hypertension are changing, and we do need to be aware of these so that we can adapt our strategy to treat hypertension in the best way possible. So I'm going to share my slides and begin by showing my declaration of interests. I have been a consultant or provided lectures for several pharmaceutical companies in the field of hypertension. So I have 5 main messages today for all of you, and this is my key message number 1. Despite improvements in the detection and treatment and control of blood pressure, hypertension remains the leading risk factor for global disease burden. And I'll show you the data. So these come from about 20-something years ago when the World Heart Organization looked at the several risk factors responsible for global mortality. And here is the ranking for the top 20 risk factors responsible for global mortality about 2 decades ago. And as you see, hypertension is by far leading the list of 20 most important reasons why anyone dies around the world. 10 years later, this was again reviewed, and once more, the leading risk factor for global disease burden remained to be high blood pressure. Another almost 10 years later, so now we are sort of looking at this every 10 years, getting closer and closer to today, we still see that high systolic blood pressure is the leading risk factor around the world, accounting for over 10.5 million deaths. So hypertension remains the number one reason for mortality. It is also a very important reason for myocardial infarction and also for strokes. And we have quantified this in the InterHeart study on the left and the InterStroke study on the right. From the InterHeart study, which covered all several different countries from all parts of the world, whether they are high income, middle income, or low income countries, myocardial infarctions, about 18% of them are attributable to high blood pressure. And strokes, again, the InterStroke study also taking place in many countries from different regions in the world and different levels of economic status. We also see that hypertension is responsible for many strokes. It's responsible for about 35% of all strokes. So hypertension is the leading cause of death, and it is a huge cause of myocardial infarctions and strokes. Now, message number 2 is that because hypertension creates this huge risk of cardiovascular disease and cardiovascular mortality, we must see the patient with hypertension as a patient at risk for cardiovascular disease. And so we must evaluate cardiovascular risk in every single person with hypertension. This risk assessment has tremendous implications in clinical practice. It, on the one hand, influences the blood pressure level from which we have to start treatment for blood pressure lowering. On the other hand, it also influences the intensity of blood pressure lowering treatment and which blood pressure lowering agents we will actually be using for each patient. And third, it also influences how frequently we should be seeing these patients during follow-up. And finally, whether they need other interventions, such as statins, for example, to further reduce the risk of hypertension-mediated complications, which I've shown to you are mainly cardiovascular. So how do we assess cardiovascular risk in people who have hypertension? Well, on the one hand, we base that risk assessment on the level of blood pressure itself. Patients with a grade 3 systolic blood pressure or diastolic blood pressure are automatically very high or high-risk individuals. Patients with lower grades of hypertension have a more variable cardiovascular risk. And that is based on several things. On the one hand, on how many other risk factors are present. This is for patients in primary prevention, but also on whether diabetes is present, which when present together with hypertension automatically increases the risk of patients, but also whether chronic kidney disease is present, hypertension-mediated organ damage, such as albuminuria or left ventricular hypertrophy, and finally, patients who are in secondary prevention with established cardiovascular disease or have a more advanced chronic kidney disease, at least grade 4, that's an eGFR below 30, are automatically at very high risk. So for some patients with hypertension, those particularly with higher levels of systolic or diastolic blood pressure, or with CVD, CKD, diabetes, or hypertension-mediated organ damage, the risk is quite obvious. For the others, we should be using risk calculators. Now, these depend which part of the world we're from. In Europe, we now have the SCORE2 and the SCORE-OP, which we should be using to evaluate cardiovascular risk in those hypertensive patients that do not have established cardiovascular disease nor chronic kidney disease, the target organ damage, or diabetes that is long-standing or with complications. But in any case, we must always, in every single patient, assess cardiovascular risk. Now, a very important observation is even when hypertension is very well controlled, the risk of cardiovascular disease is still increased. This is why we need to look beyond only controlling blood pressure levels. We need to look at LDL cholesterol. We need to look at HbA1c, whether the patient is obese or not, or smoking, because everything else can also be contributing to the risk of cardiovascular disease. Now, we're still not 100% sure why cardiovascular risk is still increased even when we have well-controlled blood pressure levels in patients with hypertension. One of the reasons we think might explain this is that part of the cardiovascular risk in a person with hypertension might be genetically determined. And you know, so far, genetic risk factors are not modifiable. So since we cannot do anything about them, maybe that's why these patients have a higher risk of cardiovascular disease, even when we get their blood pressure levels to very good control. The other reason is that we often begin treating patients when their risk of cardiovascular disease is already high or very high, and they already have structural or at least functional changes in the cardiovascular system, such as arterial stiffening, left ventricular hypertrophy that may be at least partly irreversible. The other reason is because we know from many observational studies that patients with hypertension often have other cardiovascular risk factors that are not being adequately controlled as well. So maybe this is why even with good control of blood pressure, you still see an increased risk of cardiovascular disease. The one other last thing, which is something that is going to be deserving more attention in the years to come, is that when we say that blood pressure is controlled or not, we mainly use blood pressure measurements in the office, but we know that these are not the most accurate forms of assessing whether blood pressure is well controlled, and that we may be needing other ways to assess whether blood pressure is really well controlled or not, such as 24-hour ambulatory blood pressure monitoring. Now, my third message is that the magnitude of blood pressure lowering is the major determinant of reduction in cardiovascular risk. But the choice of antihypertensive drugs is relevant for the prevention of two increasingly important hypertension-mediated complications, which are chronic kidney disease and heart failure. So what I mean by this key message is that most of what you need to do when treating a patient with high blood pressure is simply reduce blood pressure, no matter how you reduce the blood pressure. In other words, no matter which drugs you choose. But for certain complications that are caused by hypertension and that are increasingly important in public health, it does matter how, in other words, which antihypertensive drugs you are choosing. So this is why we treat high blood pressure. I've shown to you that we should be treating it because it's the #1 reason of death worldwide. I've also shown to you that it is a major cause of strokes and heart attacks. But it also causes dementia, cognitive decline, heart failure, atrial fibrillation, valvular heart disease, sudden cardiac death, aortic syndrome such as aortic dissection and aortic aneurysm, peripheral arterial disease, end-stage renal disease, retinopathy, and even erectile dysfunction. So we really don't treat high blood pressure because blood pressure levels are not looking good. We treat high blood pressure because of the complications that blood pressure, when it's high, can cause. Now, as I mentioned to you, two of these complications, which are chronic kidney disease and heart failure, are rising important public health issues over the world. While we are seeing success with gradual declining rates of mortality from ischemic heart disease and stroke around the world, we are not seeing the same for CKD, whether it's due to hypertension or to type 2 diabetes. Mortality from chronic kidney disease has been rising over the recent years. The other problem, heart failure, is also an increasingly important problem in many countries around the world. This is data from the United States, but I can say to you that even in my country, in Portugal, we are seeing exactly the same thing. While mortality has been declining from myocardial infarction and also from stroke, we see that overall for the totality of cardiovascular diseases or diseases of the heart and circulatory system, the decline in mortality has now slowed down and it's actually starting to rise after more than 2 decades of always coming down and down every year. So this is bad news. And one of the major reasons why it's happening in several countries is because heart failure mortality is on the rise. We have more and more patients dying from heart failure. Now, heart failure and CKD are important complications of high blood pressure. So going back to the choice of antihypertensive agents, if you look at these results, which are a meta-analysis of the blood pressure lowering trials, you can see that it really doesn't matter how you reduce blood pressure. As long as you reduce systolic blood pressure, you get a reduction in all cardiovascular disease, whether it is coronary disease or cerebrovascular disease, and even whether it's fatal or non-fatal forms of cardiovascular disease. And this is true regardless of whether you are in primary or in secondary prevention, and whether you are old or rather young. So looking at this, it seems, well, forget about how you lower blood pressure, just get the blood pressure down. But it's not exactly so, because there are some differences in the capacity of the different blood pressure lowering agents to reduce complications caused by heart failure. And this is clearly shown in one recent analysis from the All-HAT trial, which is one of the largest trials ever performed in hypertension. It was concluded about 15 years ago, but still has very important lessons that it is giving to all of us. In the All-HAT trial, it was clearly shown that blood pressure lowering was responsible for only about 13% of the effect that the antihypertensive medications have on the risk of developing heart failure over the coming years. So it looks like what you need to do in a hypertensive patient to prevent heart failure is much more than just blood pressure lowering. So what is it? Well, the All-HAT investigators clearly found out that you need to protect the kidneys, because the change in GFR accounts for more than half of the risk of developing heart failure when you're taking antihypertensive medications. So the lesson they gave us from this analysis is that we need to choose antihypertensive medications that prevent the decline in eGFR if we want to control the risk of heart failure among patients with hypertension. And remember, this is a particularly important risk to control because it's on the rise, just as it is for the case of CKD. So it doesn't really very much matter which agent you're using to lower blood pressure if you're looking at the prevention of myocardial infarction. They are all quite good at preventing heart attacks in hypertensive patients. And there also isn't very much of a big difference when it comes to the endpoint of all-cause mortality. They're almost all about the same, with the exception of beta blockers that are less effective than the other agents. But when it comes to stroke, there are significant differences. Calcium channel blockers and ARBs are more effective at preventing stroke than, for example, diuretics or beta blockers. And to prevent kidney failure, we certainly need to be targeting the use of agents that inhibit the renin-angiotensin system. When it comes to heart failure, diuretics are particularly important, and also this altogether means that if we want to prevent the two most important complications that we are seeing nowadays for high blood pressure, in other words, heart failure and kidney failure, we should be using certainly agents that target the renin-angiotensin system. Now, my fourth message is that for most patients with high blood pressure, the current guidelines recommend that our first-line choice should consist of a combination of a RAS inhibitor together with either a diuretic or a calcium channel blocker given in a single pill. So this is the treatment algorithm that has now been updated by the most recent European Society of Hypertension guidelines, which were published less than 6 months ago. The recommendation remains that the initial therapy for most patients with uncomplicated hypertension should be an ACE inhibitor or an ARB, together with a calcium channel blocker or a diuretic. Now, we should prefer agents with long duration of action so that we can facilitate taking them as a single pill a day. And we should prefer fixed dose combinations so that we keep doing this with one pill only. And we should also prefer taking medication in the morning because of improving adherence. Now, the only patients where you can start treatment with only one agent, in other words, monotherapy, is 3 types of patients. One, if you have rather low high blood pressure, so it's not significantly increased blood pressure, it's below 150/95, and a low cardiovascular risk, or if you have a fragile patient or an elderly patient, or if you have normal high blood pressure, but with very high cardiovascular risk, particularly patients who have coronary artery disease. Now, this will bring about 60% of patients to their target level of blood pressure. For the remaining 40% who will not be controlled, we go on to step 2, which is using a triple combination of an ACE or an ARB together with a calcium channel blocker and a diuretic, which we again should be doing as a single pill. You can try, before going to the triple combination, to still use a dual combination, but with a different type of dual combination, more intensive, more potent agents, or otherwise titrate each one of these drugs to the highest possible dose of them. But otherwise, you do the triple combination, which is the most commonly used approach. And with this triple combination, it is estimated that we will be able to control about 90% of all hypertensive patients around the world. Now, when this is insufficient, then we do need to consider whether the patient might have resistant hypertension, in which case we go for a referral to a specialist. Beta blockers can be considered at any stage of treatment as long as there is a compelling indication to give a beta blocker, such as some concomitant medical condition, or for example, patients that have had a myocardial infarction and have got left ventricular systolic dysfunction. Now, there are many reasons why guidelines over the past years have said we should, whenever possible, use the smallest number of pills possible and prefer fixed dose combination pills. And I just want to highlight one of the reasons because it is very important. One of the most important, probably the most important reason to explain why blood pressure is not at goal is lack of adherence due to an excessive burden of pills, too many pills that patients are taking. So by using single pill fixed dose combination therapy, we can improve adherence, convenience, persistence, and ultimately effectiveness of treatment. I also want to justify, show the rationale why guidelines have now considered for a number of years that the backbone of treating hypertension is inhibiting the renin-angiotensin system. It is always there from step 1. And this is because the angiotensin system is responsible for progressing the structural and the functional damage in patients with high blood pressure, ultimately leading to the development of end-stage renal disease or end-stage heart disease, such as heart failure, and then cardiovascular mortality. Now, for those patients that are resistant to triple therapy, the recent European Society of Hypertension guidelines also have an algorithm. I won't go too much into how to approach these patients, as they will be approached in referral centers. But it does depend on whether your GFR is above or below 30, which agent you should be getting next. It is likely that you should be getting spironolactone in case you are G1 to G3 CKD. But you can also join a beta blocker or an alpha-1 blocker or a centrally acting agent. For patients who have more depleted, more impaired renal function, chlorothalidone is the preferred diuretic to join here, with the other options also available. Renal denervation should only be considered after added medical drug therapy and if GFR is above 40. Now, what about the goals for office blood pressure? Well, regardless of your age, the goal for diastolic blood pressure is in between 70 and 79, and we should be avoiding a diastolic blood pressure below 70. Now, for systolic blood pressure, the goal depends on age and some other features. If you are below the age of 65, the primary aim is to get the systolic down to 120 to 129. If you're in between 65 and 79, it should be in between 130 and 139. But if patients tolerate lower levels, that is okay to go down to closer to 120. For patients who are in the same age range and have isolated systolic hypertension, the primary objective should be to go to 140 over 149 of systolic blood pressure. But if patients can tolerate going a little bit lower to 130, that's okay. But be careful to not lower the diastolic blood pressure too much. And the same applies for patients who are 80 or above. For those, the primary objective is in between 140 to 149. And if tolerated, you can go down to 130, but not lower than a 70 of diastolic blood pressure. Finally, combination therapies with valsartan, amlodipine, and hydrochlorothiazide improve blood pressure control using a single pill and with agents that have got proven cardiovascular and renal protection. Valsartan is a very well-studied agent. It has been studied in patients with hypertension, post-myocardial infarction, patients with heart failure, and also in patients with type 2 diabetes and increased urine albumin-creatinine ratio. Overall, valsartan has been shown to decrease all-cause mortality, to reduce heart failure hospitalizations, to improve heart failure symptoms, and reduce the progression of heart failure. It's also been shown to reduce albuminuria and to improve return to normal albuminuria, and also to reduce incident atrial fibrillation and even new onset diabetes, which is very important since we know that many patients with hypertension have got pre-diabetes. Amlodipine is another very well-studied agent. It's been studied in a big number of patients and a huge number of clinical trials as well, against several other agents, trials in the field of hypertension, in the field of coronary artery disease, and also in the field of diabetic retinopathy. Overall, amlodipine has shown that it's a very good agent to reduce coronary events among patients with hypertension, and it is the most effective agent at reducing strokes. It is more effective than diuretics, beta blockers, ACE inhibitors, and ARBs. So this is why we see so many combination therapies around the world available using amlodipine as one of the agents. Amlodipine has also shown in several trials to protect the kidney. Another important aspect we need to consider, remember, chronic kidney disease is a complication of hypertension, and it is one of those complications that is rising in importance. And we've seen in the ACCOMPLISH, in the ALLHET, and the ASCOT BPLA trials, all these trials have shown that amlodipine decreases the decline in renal function, it reduces the development of renal impairment, and it is at least as effective as an ACE inhibitor to prevent end-stage chronic kidney disease. Finally, before going into a clinical case, I want to share with you some data to show that this combination therapy can actually keep many patients on a single pill and at their goal for blood pressure. This is a study in which patients were randomized to either hydrochlorothiazide with amlodipine or valsartan with hydrochlorothiazide or amlodipine with valsartan or valsartan with hydrochlorothiazide. But the latter group, after 1 week, was forced to titrate to amlodipine, valsartan, and hydrochlorothiazide 5, 160, 12.5 milligrams respectively. So this is a nice study to show what happens with using triple therapy also in comparison to combination with only 2 agents. And what the authors showed is that by using triple therapy, you can still keep patients with 1 pill only and get more reductions in systolic and also diastolic blood pressure that are greater than just compared to what you get with the dual therapy. And the blood pressure control rates were significantly higher than triple therapy. So we're rather fortunate to also have triple therapy available in a single pill because that keeps very good adherence and also at the same time allows treating patients more easily to get to their goal for blood pressure. And we need not fear, we shouldn't be scared about the fact that maybe 3 agents might lower the blood pressure too much. It's been clearly shown that these particular 3 agents, they reduce blood pressure more if the blood pressure is very high, and they reduce blood pressure to a smaller degree if blood pressure is not too high. So we get a rather safe and well-tolerated blood pressure reduction for different levels of blood pressure across the spectrum. So this is a patient that was referred to me by a family physician to investigate ECG changes. He had no prior relevant clinical history. He was a smoker and had high blood cholesterol, just as his father has. And so he was on a rosuvastatin 10 milligrams once daily, according to his family physician. He was quite sedentary. He did not have a family history of premature cardiovascular disease. He was clearly obese with a BMI of 32 and had a rather increased abdominal circumference. His blood pressure was 167 over 104, and the remaining physical exam was unremarkable. His lab reports he brought along to the appointment was remarkable, particularly for the renal function. We could see that creatinine was only slightly elevated, but this was a GFR already of 58, so a grade 3 level of chronic kidney disease. Urinary albumin creatinine ratio was normal. This is his ECG. It did have indeed changes in the ventricular repolarization, but there were no voltage criteria for left ventricular hypertrophy. He had an echocardiogram which showed that his left ventricular mass index was still normal, although in the upper limit of normal. So altogether, we have a hypertensive patient that has got grade 2 hypertension with a systolic that is above 160 and a diastolic above 100, with at least 2 other risk factors, which were dyslipidemia and smoking. At least those other 2, if we consider his abdominal obesity, that is also a significant risk factor. But then also with an eGFR that is below 30, below 60, so actually at a high risk of having cardiovascular events. This was the medication he was initially put on was olmesartan with amlodipine, a fixed dose combination of 20 and 5 milligrams respectively. And 3 weeks after that, he had a 24-hour ambulatory blood pressure measurement, which showed his average systolic and diastolic blood pressures were still not well controlled, whether it be throughout the wake period or when he was asleep. This is the actual graphical report, also showing that he did not have a significant decline or an adequate decline in the nighttime systolic and diastolic blood pressure on this medication. So we changed into a fixed dose combination of valsartan, amlodipine, and hydrochlorothiazide. And this, after several weeks, got his 24-hour blood pressure down to 112/76, which is well controlled. This was good control both in the awake and in the sleep period. And here again, you see the actual measurements throughout the 24-hour period, and this time showing also a nice dip both in the systolic and the diastolic pressure. So to conclude, despite improvements in the diagnosis, treatment, and control of blood pressure, hypertension remains the leading risk factor for global disease burden. We must evaluate cardiovascular risk in every person with hypertension. That is the main reason why we are lowering blood pressure. It's not to make blood pressure look nice. It's to reduce the risk of cardiovascular complications and renal complications related to hypertension. The magnitude of blood pressure lowering is really the most important determinant of reduction in cardiovascular risk. But to prevent chronic kidney disease and also heart failure as complications of high blood pressure, we need to choose which antihypertensive agents we are going to actually be using. Now, regardless of our choice, first-line approach to blood pressure lowering for the majority of patients with hypertension is a fixed-dosed combination, so a single pill of either a RAS inhibitor and a diuretic or a RAS inhibitor and a calcium channel blocker. But when using combination therapy with these agents that I've shown to you who have proven cardiovascular and renal protection, and they are valsartan, amlodipine, and hydrochlorothiazide, this will allow us to not only use effective agents for reducing cardiovascular and renal complications, but also facilitate adherence to treatment by allowing more patients to get good blood pressure control using a single pill. Thank you for your kind attention. I'm now available for any questions you may want.
Thank you, Dr. Carlos, for the interesting lecture. If anyone have any question?
Thank you for this highly relevant presentation. My questions, are we, when treating hypertension, are we treating to lower the figures, the numbers? As you said, the studies proved that just lowering it 5 millimeters have effect, or we have to treat the pathology. So that's why we should use any of the RAS medication. And if it is just for the agent, for the drug we use, as you said, for example, the amlodipine, which is the most studied drug, still we didn't show it in the guidelines in different society of hypertension as a first-line medication. So if I saw somebody would control the blood pressure on agents is not a RAS, for example, calcium channel blocker or beta blocker, shall we stop this and we change it? Shall we continue? Especially, as you said, the CKD and chronic kidney disease have a genetic genetic etiology. So it's mainly and genetic. So we are, for me, it's a bit confusing.
Well, thank you for your important questions. Number one, indeed, we should be treating blood pressure because of the pathology, not exactly because of the blood pressure values. The blood pressure values are certainly to be used to monitor the response to the treatment we are getting as well, but we should be thinking about the pathology. High blood pressure is a mediator of more cardiovascular disease and more chronic kidney disease. And the way this happens is by overactivation of the renin-angiotensin system. So inhibition of that system is really critical to avoid the lesions caused by hypertension. But we also need to lower blood pressure to sufficiently low levels. And the higher the risk the patient has, the more we should be lowering. And in fact, the proof that we should be lowering blood pressure more based on the risk of cardiovascular disease than on the actual blood pressure values comes from the fact that even in patients who only have normal high blood pressure, so that's in between 130 and 139 of systolic and 85 and 89 of diastolic, so that's not yet hypertension by European guidelines. So even without hypertension, we are recommended to lower blood pressure using monotherapy with a RAS inhibitor in order to reduce the risk of cardiovascular disease. This is because there is that continuous relationship between systolic blood pressure and the risk of cardiovascular disease down to about 120, 115 millimeters of mercury at least. So if your risk is very high, it really makes a big difference to get bigger lowering of blood pressure. If your risk is not too high, you don't need to be too strict about blood pressure control, because it will only get a little bit better, the risk, if you change a lot the blood pressure level. But with high risk, even a small change in blood pressure makes a big difference. So we need to be much more strict and intensify the follow-up in patients who have a higher risk of cardiovascular disease. Now, regarding your point about calcium channel blockers, the guidelines indeed have a sort of a clear statement about the importance of using a RAS inhibitor as the backbone. Then they leave it up to us to choose in between a calcium channel blocker and a diuretic. We can choose either one or the other. There are significant differences among the calcium channel blockers. They are not all alike. Amlodipine has been the most studied one in hypertension, and indeed, it is a good drug to provide protection of the heart, protection of the brain, and also protection of the kidneys. And also protects against heart failure, and this was very nicely demonstrated as well in the ASCOT study, by reducing the central blood pressure. Now, the other thing is also about diuretics. They are also not all the same. There's hydrochlorothiazide, and there are the thiazide like diuretics, and there are even other potassium sparing diuretics, etc. They're not all the same. So we need to be careful when we choose the diuretics, which ones are also the more appropriate one for our patients, also based on the eGFR that our individual patient has. But it really is up to us to choose between a calcium channel blocker and a diuretic. We can use either one or the other. Both are good choices on top of a renin-angiotensin system blocker. But when we need more than two, then it's obvious that we should be going for all three. I hope I've been clear in answering your questions, but if I have not, please just let me know.
Quite clear, especially you remind the consideration of the target blood pressure with the numbers, with the risk factors number. So it's quite clear. Thank you.
Thank you.
Thank you, Dr. Carlos, for your comprehensive talk. My question about the timing of taking antihypertensive. There is any difference between morning and night dosing? Because there's some studies suggest that night dose could reduce the dipping in the systolic and systolic blood pressure, and this could reduce the complication like stroke.
Thank you very much. That's a very timely question. And it goes to a trial that's also got the name time in it. So based on pathophysiology, we have been aware, many of us have been aware that there is a reason to prefer using certain blood pressure lowering agents more in the evening than in the morning, because the systems which they target are more active in the evening than during the day. And it also because it's when you have high blood pressure in the evening that your risk can be even higher for cerebrovascular and coronary complications as well. So some have advocated that we should be potentially using blood pressure lowering agents, preferably in the evening. Now, there has been a lot of discussion. There were a few studies that did have significant limitations to their design and the methodology. And so this question was addressed in a properly designed trial called the TIME trial that was presented slightly over a year ago. And this trial concluded that it really doesn't matter very much whether you give it in the morning or in the evening. As far as cardiovascular events go, there couldn't be a demonstration of a difference. However, adherence was significantly better when medication was taken in the morning. In a clinical trial, adherence is much better than in the real world. So maybe that's why there wasn't such a big difference between the two times the treatment was given in the TIME trial. But translating this into the real world, if better adherence is in the morning, then this is very significant, and it can make a very big difference as to the number of events that we can prevent by treating preferably in the morning. So my personal practice is to always prefer using morning dose medication if I only need to give medication for blood pressure lowering once a day. If I do need to go for more than 2 pills, for more than 1 pill a day, then I might consider giving one of the pills in the evening to optimize blood pressure control and the other in the morning. But not always I will do this. Often I will give all of the medication in the morning, because that is really the time in which I find my patients less often forget to take medication.
Yes, thank you.
First of all, I need to thank Mr. Carlos for these lectures. My question is regarding the RAS inhibitor. When combination with hydrochlorothiazide, always there is a risk of profound hypotensions when you are taking after breakfast. As you said before, you said this is as your practice, that preferably, for example, in my practice, we give an ACE inhibitor or RAS inhibitor at night to avoid profound hypertension at a single dose for testing dose, for example. Is that right, or you have any your opinion regarding this?
Well, that's a very important question, and I believe it's probably quite important because of the part of the world where you practice, which is something I also share a little bit. So we in Portugal have a big difference between temperatures in the wintertime compared to the summertime. there is a huge distance between summertime temperatures and wintertime temperatures. And so often I am faced with a situation in which I have to change treatment during summertime because the weather, when it becomes too hot, patients, they start to dehydrate a little bit, particularly if they're not being careful about taking sufficient amounts of water and other liquids. And they can get dizzy, and they can even become quite hypertensive, and sometimes even have a fainting spell. So we need to be careful in the summertime. Some of my patients that are very well controlled in the wintertime, using a combination of drugs where there is hydrochlorothiazide, I will drop the hydrochlorothiazide component in the very peak of the summer, particularly when they're going out for holiday season. So they're going to be about 2 or 3 or 4 weeks very exposed to sun and very hot weather. I will reduce the medication somewhat and then get them back on the hydrochlorothiazide with the other drugs as soon as that season goes away. Now, one way to avoid doing this is by asking patients or alerting patients that they might get more hypertensive in the summertime or with the very hot weather if they do not be careful about hydration. If they are adequately hydrated, there shouldn't be a reason why, if they keep on taking hydrochlorothiazide, they would still become too hypertensive. So as long as they have good hydration and that they do not be excessive in reducing salt. I mean, some patients, it's because they have this perception that they need to abolish completely salt from their diet, and then they automatically become too hypertensive whenever you give them any blood pressure lowering agent, particularly if that's hydrochlorothiazide. But many patients, even in the hot summer, will tolerate, most of them do tolerate taking hydrochlorothiazide as long as they keep on good levels of hydration. That's very important.
Okay, thank you. I have more questions. Regarding some patients who have type 2 diabetes, when we did a couple of investigations, we saw some results which high uric acid level. So this is uric acid level. So chlorhydrazide, which has increased the rate of uric acid level. Also, it is valsartan, also the combination between valsartan and hydrochlorothiazide, which has increased uric acid level as well. So even if I educate patient properly that you have to decrease food, which is rich of purine, and try to drink enough water, still uric acid is still high. So I think is to switch valsartan to losartan, which is preferred at first line for patient who has uric acid level high, and try to decrease the dose of hydrochlorothiazide and switch it by amlodipine. Are you agree with this or not?
Well, I do not switch the ARB because of uric acid levels in my clinical practice. Losartan has got a particularly significant issue. It is one of the weakest ARBs, and if you do not do at least 100 milligrams of losartan a day, it is very likely that you do not get 24-hour protection. So 50 milligrams is absolutely insufficient to control blood pressure throughout the 24 hours. So I avoid using losartan, and I only keep patients who come to me on losartan if they're taking 100 milligrams, and I'm happy in that they have indeed got 24-hour blood pressure control. I guess another reason why I do not use losartan that much, and I actually switch away from losartan many times, is because I'm a heart failure specialist, and in heart failure, losartan actually failed to prove it is as effective as ACE inhibitors in those patients. And so it's not recommended as an ARB you can use in patients who are intolerant to an ACE and have got heart failure. So I tend to go away from ARBs. What do I do in patients who come up with high uric acid levels and they're taking blood pressure lowering medication, well, this with 12.5 or 25 milligrams of hydrochlorothiazide, it's not usually that much the fault of hydrochlorothiazide for the patient to come in with hyperuricemia. That low level of hydrochlorothiazide doesn't get that much increase in uric acid levels, but you can see bigger increases with other diuretics, particularly, for example, chlorthalidone. That can give a much higher level of uric acid, and you need to be careful about using chlorthalidone in patients with high uric acid levels. So what I tell patients is I give them advice on their diet, on what they should be doing, what types of foods they should be reducing in order to avoid high uric acid levels. But if they have had symptomatic hyperuricemia, then I propose they do take uric acid lowering medication as well. But to summarize, I do not change the ARB. I do have a particular attention to the diuretic I'm using, and then I give lifestyle diet advice so that they can try to lower through the diet their uric acid levels.
Thank you.
Thank you, doctor. Last question.
Hello, Professor Carlos. Thank you for this exciting and interesting lecture. I'd like to take this opportunity to get some of your benefit and expertise. We have, as endocrinologists, we have a common scenario where a type 2 diabetic patient either have a newly onset primary hypertension or microalbuminuria, suggesting maybe nephropathy. And we start antihypertensive. Our common choice is usually ACE or ARB, as you know. And what I'd like to ask is any hints regarding adjustment of dose? Is our aim to keep the blood pressure low in terms of values? Considering potassium might rise, I'm talking about patients with type 2 and particularly those with impaired renal function or chronic kidney disease, not end-stage disease. And in most of these cases, the responsibility of managing the blood pressure lies on us, not on the nephrologist.
Yeah.
And we are sometimes bewildered. If we increase the dose of ACE inhibitors, we get some rise in potassium or whatever. Should we focus on blood pressure values or albuminuria or glomerular filtration rate? Or what's the hint? What's the clue? Where is the catch here? Got my point. What
Very
should
good
be,
point.
What should be my aim? Some of these patients are also intolerant to ACE inhibitor, either because of dry cough or it's not efficient or whatever. And what's the next choice? These are my questions. Thank you.
Thank you. Very good practical points. So first of all, ARBs actually have the better level of or the better amount of evidence in type 2 diabetes nephropathy. ACE inhibitors, which the ones that were chosen in the time in which trials have been done in nephropathy related to type 1 diabetes. So ARBs are good drugs, and if the patient is intolerant to an ACE because of cough, I would not hesitate to change to an ARB. Blood pressure control is extremely important for preventing the progression of chronic kidney disease. So we should optimize blood pressure control, bringing it close to 130/80. Those are the recommended targets at the moment, not lower than 130 of systolic blood pressure is good for preventing the progression of chronic kidney disease. So blood pressure medication should be intensified. You should add on agents as needed in order to get the blood pressure down to about 130/80. Now, if this is insufficient and you still got the impaired GFR, you must in my opinion, and in particular in a patient with type 2 diabetes, add an SGLT2 inhibitor. These have shown, on top of renin-angiotensin system inhibition, to prevent the progression of chronic kidney disease and, many other benefits. They prevent heart failure hospitalizations in these patients. They improve life expectancy as well. And they can slow the need for and delay the need for renal replacement therapy by many years if you start them quite early on in the progression, in the evolution of chronic kidney disease. So that is certainly a second step. I would also remind us that we still have another third possibility, which is finerenone. I'm not sure if it's available in your region. I would imagine it is. Finerenone has also been approved for diabetic nephropathy with proteinuria. And so in these patients, besides the good blood pressure control down to 130/80, using renin-angiotensin system inhibition as part of that blood pressure lowering regimen, and the SGLT2 inhibitor, you can still consider finerenone as well to reduce the proteinuria in those patients, which is a very well recognized marker of not only progression of kidney disease to end-stage phase, but also of cardiovascular mortality in these patients.
Thank you, Dr. Carlos.
Thank you.
Thank you so much. Really enjoyed the discussion and hope to see you soon, hopefully.